Jim Weiscarver is a friend of mine, and he said, "You're batting cleanup." And I'm not so sure I want to bat cleanup after those three awesome presentations. But I'm a Kansas City Royals fan, and we have not had a good season, so I'm sure I can bat cleanup as well as our cleanup hitter for the Royals has done. I really appreciate the opportunity to learn, and I've learned an awful lot today. Those were three awesome presentations by each of you. Michelle, your story, oh my gosh. And Kim, your story. I didn't think pathologists did go out and make rounds and see patients. And Anthony, your story. And there's one really theme that pulls it all together, and that's caring. The professionals caring about the patient caring about the professionals, and the patient caring about other people and sharing their experience. And I think it's just awesome. Kudos to all three of you. Wonderful presentations. So what's my background? I'm a family physician. I'm entering in my 40th year of practice. I've been in the same practice for 40 years, so I have a huge advantage over any pathologist because I have continuity of care. And having a relationship with patients makes a tremendous difference in how you can communicate and listen and hear. I'm going to go through this will feel like a classroom now after what we just had, these enthusiastic, really tremendous talks. But I'm going to follow through on doing this, and we'll try not to make it that much classroom. I hadn't thought about it until I was asked to give this presentation, that why aren't the pathologists and why shouldn't pathologists be part of that team? They are, but it's a behind-the-scenes team. Even for most health professionals, the pathologists are seen as behind the scenes, unless you're in a specialty that uses them every day. I'm a family physician. I use them every day. I just don't realize it because they're helping me interpret the labs. They're helping me interpret cultures. I don't do surgery, so they're not helping me with pathology specimens. But quite frankly, the people that I'm seeing need that just as much in a different way as the rest. So I'm going to talk a little bit about the basics of communication. I'm going to talk about some specifics, focusing on one area, and that's delivering bad news. And I'm going to tell you that there's not a day that goes by that I don't have interaction with a patient where I don't learn something more about medicine and something more about myself and the way I interact with people. So you can learn from every interaction you have. Now, what do you see when you read this on the screen right now? So that's just the pathologist would only see it that way. Because most of the people I've shown it to in my department say opportunity is nowhere. But I think it also tells you communication is, and Anthony kind of brought this out, can be what you think you're saying and what people are hearing might be different. So you can read this in different ways. And I thought it was a good way to start into the way communication might go forward. Whoops, that's not the right one. So communication is verbal, it's nonverbal. A lot of what people pick up on is not what we say, but how we phrase it, how we deliver it, our body language, and I'll get into that a bit more. What does a patient want in good communication? Trust. They want someone who cares. They want expertise, and they want to have some degree of autonomy. We're pretty good in medicine about being directive and very authoritative, and we are the experts, but that's not the way we're going to have our best relationship in communicating with our patients, whether it's you for a 1 or 2 time basis with sharing pathology results with the patient, or on a long-term basis, like our bone and blood bank colleague has. What does the physician want out of communication? What's best for the patient and family, I hope. Clear and honest communication. They want to build a trusting relationship. Even though it only may be 1 or 2 times, you never know how much more that might become. And I think most of us want to care and communicate that we're caring. I don't think about this, but silence is a form of communication. And sometimes silence is important. And particularly when you're delivering bad news, listening a lot more than talking, and not saying anything at times when it feels tremendously uncomfortable, the silence that's going on there, to let things percolate and let things come forward. So, what are some of the challenges? As I told you, I have a huge advantage over a pathologist because I have a long-term relationship with many of my patients. But when I'm making rounds on new patients or someone else's patients, and maybe the first time I see them, that's a new relationship, I have to put myself back into the fact that I need to slow down. A lot of us were not trained. We're not trained either in medical school, we weren't trained in our residency. It's not important. What has been impressive to me as I prepared for this is how many pathology departments actually have taken this serious and are training their residents and their students and their faculty in these communication skills. Experience. Do you have the desire? And I know it used to be this way. I don't think it is so much anymore. There were laws that kept you from sharing some information with patients. It was only the primary care physician or the physician providing direct care that was allowed to do that, but I think most of that has been taken out by CMS, and we won't there. But your institution may have practices or rules and regulations or bylaws that you might find different. And I find it challenging now with communication because so much of it isn't direct, because patients have access to their medical records online and they will text you, they will message you, they will call you. And that, as I would say, is not the best way to communicate a lot of the information that we're being asked to communicate. So we have to learn a new skill set also. Active listening. I should have underlined the word listening. We're good at talking, we're not as good at listening. Open-ended questions. And I learned something here as I was reviewing for this. A lot of times we don't want to ask those open-ended questions. Why? Because we're afraid it's going to be out of control. We're going to be off over here. But there's some literature that actually says if you asked this question, use something instead of anything, because a lot of times what we'll say at the end, is there anything more you want to know? And that could be anything. Change it to something. Is there something more you would like to know? Because that focuses it really back on the conversation you were just having. And it allows you to be in control. And if you looked at the literature, by doing that, it didn't increase the time that you would have spent there talking as people had evaluated this. So for me, and again, I learned there, something instead of anything when I'm asking those questions. And that's a caring question that you ask at some point or at the end, that you really care. Oh, I'm not going to go through these, but I am going to say this. Sit down. Before you start talking, sit down. Take this thing, turn it off. And more importantly, maybe just if you carry a pager, take the pager off and set it somewhere else. a patient needs your full attention. And that is particularly true if you're trying to deliver bad news. And usually it won't be the patient by themselves, it's the patient and family. And when I say patient, I'm really talking about the patient and family. I'm not going to keep putting that up in there. Slow down. What is the difference between empathy and sympathy? Or can we use them both the same? Anybody want to tell me what they think sympathy is? This is the part of audience interaction here. Go ahead.
I think sympathy might be feeling something for someone, and empathy is feeling it with them.
Yes, and I think that's a good way to think about it. And if you look in the dictionaries, any of them, they're going to put pity at the start of sympathy, pity for one's condition or their plight that they're in. Empathy is probably the word we're really trying to use because we're trying to, if you're not that person, you can't ever know exactly what they're feeling, but you can empathize with them. Nonverbal, and for heaven's sakes, be prepared for emotions. If you're delivering bad news, particularly, it's going to be all over the place. Some people will have nothing until they leave, and then they're on the phone to you or to their family, and the family's on the phone to you or coming, but be prepared. And Anthony said that, I think if you have a plan when you go in, it's more likely to be carried through than if you just sit down. And sometimes when patients have said, I really want to have this conversation, and we've taught our residents to do this, take a step back and say, I'd love to do that. Let's do this later, because it allows them to step back and get their feet under them before they go in and say something that was meaningful to them and they thought was helpful, but turns out to be misinterpreted, or not misinterpreted, but interpreted differently on where you're sitting at the table having the conversation. Traps to avoid, technical language. We're good at that too, using our medical jargon. I'm going to be honest with you, when the pathologist or some of the specialists use some of the language and they start running these abbreviations for this disease or this thing, I'd like to say, whoop, time out, can we step back a little bit? That's medical jargon that I don't understand, but I think patients don't, so talk in their terms. And I think one of the examples I saw in one of the articles I was reading was explaining the exact scientific terminology you'd use on a tumor instead of just saying you have cancer. Most patients will understand that, but they may not understand a grade 6 astrocytoma of the whatever. And I'm not a pathologist, so you guys can get after me on that. So after you've had some conversation with them, ask what they heard, what more they'd like to hear. And it's okay for patients to say, I don't want to hear that. That's the part of where we feel we should just jam it all out there. But it's okay. Take a step back, you'll get your chance. They aren't ready, and it's okay. It allows them that autonomy that they need to have as they're working through information. Oh, I went backwards, and I'm good at that. How many of you have ever heard of spikes? That's pretty good. 2, 1, 2, 3. Well, I would encourage you, and there's a reference in there that comes from MD Anderson that Bali is involved with that has some really good communication skills. And they've gone through them. It's about communication. It's from an oncology practice, but I found it to be as good as anything else that I've read. And actually, his group in 1990 published an article in Oncologist that brought out the concept of spikes. And we teach this to our residents, and it's mostly focused on bad news, but you can use it in anything. And I'm just going to kind of take a second here going through this. First of all, what is the definition of bad news? any news that dramatically and negatively alters the patient's or family's view of their future. Anthony had bad news when he was told about his kidney disease. He's worked a long way through that. I would think it was bad news. Am I right? So setting this up, when do you want to meet with the patient? Who's going to be there? And you know, one of the things I think we're good at is saying I can meet you 3 weeks from next Tuesday. That's not going to do it. We're going to have to find a way, or whoever's going to be the communicator here is going to have to find a way that works it in a timely fashion. Get some understanding when you first sit down, and how I like to do this if it's a family is I'm sitting here, the patient's sitting next to me, and the rest of the family is there, and there's a reason that is, because I'm going to be speaking directly to the patient, not to their husband or wife, not to their kids, not to their aunts, uncles, whoever, but to the patient. And I sit down before I start talking. Set goals for the discussion, and let the patient help you set those goals. And you don't have to do this before, you do it while you're sitting there. Avoid jargon, fill in the gaps of what the patient knows, what they'd like to know, what they've been told, what they've read on the internet, what they've heard from Aunt Jody, what they have found from the doctor they go to church with, who has that much of the history and information. But ask what they know so you can clarify it and try to work through it. We talked about open-ended questions, and listen. Listen. And support. There is literature that in a Department of Surgery at Baylor, published in 2016, 91% of the residents and doctors felt that it was really important to deliver bad news. 40% of them felt trained to do it. And I would say that's probably true in my residency program, also in the first year, but I know it's not that, as we have a program that goes through all of these kinds of communication skills longitudinally through their 3 years of training. Avoid, and I have to remind myself this, avoid statements like everything will be fine. Avoid statements like I've seen, and you've put in there that miracle or this miracle or that. It's hard not to want to do that because you care and you want to provide some hope, but that's a lot taken as false hope. And I'm not making that's not my perception, that's what patients will tell you if you look at the literature on the patient side of things. Give a warning shot. I think when you sit down, you're going to say, we're here to talk about the biopsy you just had. And I want you to know in the beginning that I'm probably going to be sharing some bad news with you. They may say, stop, done, we don't want to hear it today. But if you don't give them that chance, you may go down the direction that might not be the most productive for the patient. Listen. How long can most of us listen without having to say something? I think there is studies on this. Do you know how long it is? Somebody said 30 seconds. That's about 3 times too long. It's about 10 to 15 seconds. Why? But it makes sense. What are we about? How are we trained? Gather information, gather information, gather information. We don't have time. So think about it the next time you're sitting and talking with somebody about a tough situation. Sometimes being quiet that long will allow some other things that might direct you in a better direction to go. And it doesn't increase the length of time. I'm not going to go into this because that's a whole talk on its own, but people from different cultures have different ways that they like to receive information. Families may not like their parents to ever hear that they have a tumor or cancer or end-stage renal disease. They want it shared in a different way. So be respectful to different cultures. So other factors can impact your communication with your patient and family when you're talking to them about bad news. Let's say they're in pain. How focused are they going to be in what you're talking about? They're having a particular emotional response to something else. They may have cognitive issues that doesn't allow them to really understand what you're trying to share. I'm just going to skip that one. Here are the patient's perspectives in a couple of different studies about positive communication skills. Be prepared, sit down. Sit first. It shows respect, it shows you care, it lets them know that you're interested. Listen. Be clear, be supportive, and provide some empathy. These are the negative skills. And I'm talking about patient behavior at time of discussion. It's the person who is always looking at their cell phone, looking at their, isn't really focused on what they're doing. They tried to do what may take an hour or longer in 15 minutes, and then got up or start getting up and leaving. Don't pay attention and aren't respectful and lack empathy. In summary, this is a skill all physicians need. I was really impressed as I reviewed the literature about how many departments of pathology around the country are doing exactly what they're doing at the University of Michigan, what you're doing at VCU. Arizona has a lot of projects that come out of this. Baylor does. I was talking to Dr. Weiscarver as a chair of the Department of Family Medicine. I'm embarrassed that I didn't reach out to the Department of Pathology and offer some of our training and some of our skill set. Hopefully we can do that as we move back, but I think that's another role that maybe family medicine in your institutions could benefit from assisting and helping, because two things will happen. One, you may actually learn something from us about those communication, and two, we're gonna learn an awful lot about pathology by interacting with the pathologist in a way different than what we usually do. Which is why didn't that lab get done, or for us, why did you order that? You know, I've been doing this for 40 years. I learn something new every year. One of the reasons I took the offer to come and talk to all of you is I can see you're wonderful people, but I know that from the pathologists I work with in my institution. But I knew I could probably learn something, and my gosh, have I, from the three speakers, just from listening here today. But I had to read some things that were outside what I'd ever read. So it was good there. Skills can be learned. Even if you don't think you can do this, you can practice them, and you'll be better the next time and better the next time. And you'll learn, and you'll make mistakes, and you'll say things you wish you hadn't said. But the next time you might not. The next time you might not. And every patient has an opportunity to learn. I tell this to the medical students, to the pre-med students, to anyone that I get to, is that what an awesome profession we're in, where you get a chance to learn something new every time you interact with a patient. Even if it's the same disease, it's a different patient, a different family, and different dynamics. And if you don't learn anything about medicine, you learn something about yourself as a person. Patients want and need the communication, and if we do it in a caring fashion, it'll all work its way through. You won't do it perfect every time. I never do, but I try to learn from every one of those experiences. Thank you.